So this is kind of a quick summary of some issues about transcutaneous pacing. We use transcutaneous pacing in symptomatic bradycardia to force our ventricular rate upwards and kind of bypass those SA and AV node issues in high degree block and get the ventricular rate up, therefore the cardiac output will come up. In terms of some logistics, for Zoll E-Series, their instructions say that anterior-posterior pad placement is their preferred placement, but the standard defib placement may work. So if you know you're going to need to pace right off the bat, then probably good to go AP. But if you're already into cardiac arrest and have defibrillated and you have them in the usual anterolateral placement, then just leave them there and the pacing will be adequate. For those using LifePak 15s, their instructions say that either pad placement is appropriate. Speaking of electrodes and pads, you'll definitely need your limb leads on along with the pacing pads, whereas with defibrillation you can use the electrode pads to analyze the rhythm as well as then to deliver the defibrillation. In transcutaneous pacing, the sensing of the rhythm needs to happen at the same time that pacing current is delivered, and so since we can't send signal both ways at the same time through those pacing pads, you do need the limb leads on. Next thing you do is set your pacer rate. We think 70 is a pretty good number, and then start turning up the current, the milliamps. Start turning up the current until you get electrical capture. And you want to use the least amount of current necessary for capture, but you don't want to mess around just barely moving the dial up until you get capture. Go ahead and move up the range, get capture. It's usually around 50, 60, 70 or so. So a pretty decent rule of thumb is set the rate at 70 and then quickly get the milliamps up to 70. Once you've got capture, back it down to use the least amount that you need to. While you're providing pacing, you sometimes want to know what's underneath, what the underlying rhythm is. In some cases that's just curiosity. In other cases you really do have a need to know. Zoll has the 4-to-1 button. It's a momentary contact button that as long as you hold it down, the 3 of every 4 pacing spikes is blocked, and they call it the 4-to-1 button. The LifePak 15s have a similar function. They just use the pause. Again, as long as you hold the button down, you're decreasing the pacing spikes frequency. You're dropping 3 of every 4 so that you can see that underlying rhythm. You certainly don't want to do that for very long. Synchronous or demand pacing mode is the default on both units, meaning that the device is synchronizing the pacing spike to the EKG. And so if the patient's intrinsic heart rate comes up, if their underlying rate comes up to above the rate you've set for your pacer, then there'll be no pacing spikes that are delivered. But once the pacer senses that the patient's rate has dropped below the set pacing rate and there's a demand for pacing, then the pacer will begin to deliver pacer spikes. Zoll will let you set an asynchronous pacing mode, which is not demand, which means that whatever rate you set the pacer at is the rate of pacing spikes you're going to get. And then LifePak 15 will automatically go into that asynchronous pacing mode if a lead comes off. Under the assumption that that was an accident, you still want the patient to be paced, the LifePak 15 continues to pace. As far as other issues or side effects of transcutaneous pacing, the delivery of the current is painful. The patient will experience some discomfort. Certainly your conscious patient is going to be more of an issue, but many of these patients that we're pacing have an altered level of consciousness or are almost unresponsive. And so while it's not that we're not concerned about pain control for them, they're probably too unstable to tolerate any analgesia or sedation. So fentanyl or Versed would be the 2 agents that we would be interested in using. Versed for the amnesic effect as well as the sedation. But again, if these patients are hypotensive, if they're that symptomatic that we're needing to pace them anyway, in many cases we're not going to be able to help them with analgesia or sedation. So that's kind of a really quick summary of some of the stuff we've talked about with transcutaneous pacing.